Well, welcome everyone to the ASPN webinar, where we're going to hear some of the world's experts. And I know many people will join us live today, and many of you will join us later on the website. And we expect to have close to 1,000 people eventually hear this this presentation. So I hope it really improves care around the world and access. I'm Tim Deere. I'm the chairman of the ASPN Society. ASPN is a really important part because my belief is that international collaboration makes for better practices and better patient outcomes around the world. So thank you so much for joining us. Dawood?
Yeah, thank you, Tim, and thank you, Rita, for putting this program together. As Tim mentioned, I think as we started ASPN, we really knew that there was a big desire in the international community to advance the education and learning opportunities around pain management and neuroscience. We know that the field is obviously advancing very rapidly, so we want to share the knowledge that our experts from around the world have taken on in their own practices and share it with our colleagues internationally. So the first way we're trying to do this is through our webinars, so that we can kind of reach as many people as we can. And we'll have some announcements coming here very quickly about our first in-person meeting that Dr. Tolba can maybe talk to us about a little bit later on in the program. Rita?
Thank you, Dawood. Again, welcome everyone to this exciting webinar. We have panels of experts in the field, and we're excited to kick off our second webinar for ASPN. We will have we're looking forward to have another set of webinar after this one, and then we're looking to plan our big meeting, which will happen in Dubai in early 2023. So we're looking forward to that. We're gonna start our first panelist with, we'll talk about data, patient selection, and indication for spinal cord stimulation. And we have a panel of experts. We have Dr. Van Buiten, we have Dr. Kaladi, Dr. Doshi, and Dr. Pedram Tabatabai. We're going to discuss the data, patient selection, and indication for spinal cord stimulation. And here to the panel, we're going to begin our discussion.
Okay.
So first, I would like to introduce Dr. Doshi. We're going to talk a little bit about her experience in India about the spinal cord stimulation, and I think she has a quick presentation as well to talk about. That will involve other panels as well to talk about different subjects. So the podium is yours, really.
Thank you so much, ASPN, Dr. Deere, Dr. Said, and Dr. Tolba for inviting me to this very interesting panel on spinal cord stimulation, and I'm going to present the data from India. So we published a paper on neuromodulation practice in India over the past 2 decades. So this was a survey conducted with a 20-point detailed questionnaire, which was conducted online, and the data that was collected was analyzed, tabulated, and presented in form of percentages. So basically, next slide, please. Can you advance the slide?
You got it?
Yes. So, yeah, the previous slide.
There you go.
So first, talking about the indications, the indications are very similar. This is most commonly performed for patients who have persistent post-spinal surgery or persistent spinal pain syndrome, complex regional pain syndrome, neuropathic pain syndromes, and peripheral vascular disease or ischemic pain syndromes. It can also be considered in other conditions, but the top 4 ones are the ones where we use this therapy most commonly. Next slide, please.
Oh my God.
Can we advance the slide, please?
1 second.
So the selection of the patients is based on criteria which are very similar to the ones which are recommended by NAC. Basically, any patient who has pain which is refractory to conservative modalities and conservative medical management are considered for an option of neuromodulation or spinal cord stimulation. The commonest conditions which were found to be refractory from this survey were failed back surgery syndrome or post-spinal surgery pain syndrome and complex regional pain syndrome, which are very similar to indications which are practiced all over the world, followed by, again, neuropathic pain conditions and patients with malignant pain syndromes. And almost 70% of the practitioners in India reported that 20 to 30% of their patients present with refractory pain syndromes. Surprisingly, 70% of our population and the practitioners do not practice neuromodulation, although it's an upcoming therapy now, and we have younger generation pain physicians who are realizing that this is a very important modality and can be incorporated in our practice for patients with refractory pain syndromes. Next slide, please. So the common barriers which we came across from this study to the development of neuromodulation therapies in our country were the first and foremost, previous slide please, was the cost of the therapy. There was a lack of awareness at various levels, which also restricted the use of therapy. Of course, the training of the implanters was another very common factor, which was according to about 58% of practitioners, this was the main cause for underutilization of the therapy. Access to the therapy also is limited because of limited number of centers and limited number of trained implanters who can offer this therapy. Acceptance by the patients is another major restricting factors. And we find that many of our patients have cultural barriers also, which prevents them from accepting the therapy. In addition to that, the access to therapy, availability of technology also is a major restricting factor. And last but not the least, according to the perception of our practitioner, there is a modest success of the therapy. And almost 30% of the practitioners felt that this was the reason why we had a restriction about applying this therapy on a wider scale. Next slide, please. So this survey, according to this survey, we concluded that neuromodulation for pain is grossly underutilized, and it constitutes only about 10% of the total neuromodulation implants performed per year in India, as against the neuromodulation for other neurological disorders like movement disorders. So compared to the DBS, spinal cord stimulation is relatively very less in practice. Next slide. Of course, with the younger and more dynamic pain practitioners that have started practice in India, they are always convinced that there is a very useful role of neuromodulation to alleviate pain and suffering in the patients with refractory pain syndromes. And we can enhance the benefit of this therapy to larger number of patients by improved training, awareness at various levels, more flexible options in terms of more options for the newer technology, and reimbursement approvals. If we can improve or work upon those factors, we can definitely improve the utilization of this useful modality in our clinical practice. And this can be facilitated by collective efforts of clinicians, industry support, focused academic activities by various clinical societies, and our Indian Society for Study of Pain, as well as the Neuromodulation Society, which is a chapter of International Neuromodulation Society. We are all trying to work towards increasing awareness about this very useful modality in our country. Thank you.
Thank you so much, Dr. Doshi. That was a wonderful presentation. I believe Dr. Tolba is going to jump on now here too. Certainly, I think the story that you shared in India could probably be a similar story across a lot of the international community, with access being, a big barrier. What are some things? I mean, obviously, you're doing that in your practice. You're doing neuromodulation. What are some things that you guys have been able to do so that neuromodulation for pain? You have been successful in implementing that. Especially with things like cost and training, etc.
Okay, so we, with the help of Dr. Deer and International Neuromodulation Society, we formulated the Indian chapter in January 2018, and we have been trying to do more educational activities. And in fact, we were to have the interim meeting of INS also in October 2020, which has now been postponed because of the COVID pandemic. And we hope to have it next year. And so that is one very big boost to the therapy, and we are going to have a lot of awareness. Last year, we also conducted a series of webinars on spinal cord stimulation, neuromodulation, and DBS. So we had about 14 webinars conducted over a span of 3 months, and that was again free for everyone, and we had very good number of registrations to create awareness about the basic aspects of this therapy. And of course, we have conferences. I mean, I talk about neuromodulation in most of our national conferences as well, trying to create awareness. We do workshops also. So these are our efforts, but we need to have much more support in terms of technology, especially the advanced technology to give better outcome, and of course, train the more implanting physicians as well.
Yeah, I just have a follow-up question on that. Great job with your discussion, and certainly you and your colleagues or your husband, wonderful work there. And I think you're the leader, one of the real impressive leaders in India of pain, and I appreciate all your work. I guess my question is this: we as a new society, ASPN, led chaired by Dr. Tolba, we're looking at bringing in other things like regenerative medicine, like minimally invasive spine work. So. Do you think there's a good opportunity to improve access to everything if we can have more inclusivity of all the other therapies? What's your thoughts on that?
Absolutely. So I think, I mean, besides neuromodulation, again, there are many other minimally invasive options. And we have a lot of interest amongst our young dynamic pain physicians. And we also have structured training programs now initiated by our Indian Society for Study of Pain. We have structured fellowships where we give them proper training, and that can enhance definitely the use and application of minimally invasive procedures in our practice.
Excellent talk, Dr. Doshi. And one of the things also that you mentioned is the barriers that we talk about that we face in different, developing countries. And how do you work with overcoming those barriers, especially the costs of the therapy?
So we actually are, I mean, we are working with the industry to try and, come and negotiate at times, in terms of bringing down the cost for deserving patients. And of course, we, India, we still don't have insurance support to reimburse the therapies, which is a big barrier. So we are working with the insurance companies also. There are very proactive efforts going on with the insurance companies, and once the reimbursement part is taken care of, I think we can really boost the application of the therapy.
One of my original goals as I went into the international community over a decade ago was to improve access, and I think you're making part of that happen. So thank you so much for your hard work. I look forward to seeing you more and more. I look forward to seeing you both in India at INS India, as well as in Dubai at IASPN Dubai. So thank you so much for being here today. I think this is a great way to kick this off. Dr. Tolba, you want to introduce the next panel?
Absolutely. We're very excited to introduce also Dr. Pedram. Is he here? Dr. Tabadabi, who has a long experience with neuromodulation in Sweden and would like to share his experience as well. So Pedram, are you around?
Yes, I'm here. Unfortunately, my camera isn't working. I'm so sorry. I hope you can bear anyway with my voice only. So a short presentation about the situation in Sweden right now. when it comes to neuromodulation and SCS primarily. Our main groups of patients are, of course, the FBSS patients, the neuropathic pain syndrome, and the CRPS patients. And it's often patients with a neuropathic pain in their extremities or lower back that get this treatment here in Sweden. In Sweden, we have 4 or 5 bigger centers with quite high volume, and then we have a few smaller volume centers. And the big problem in Sweden is the very long distances between the patient and the different clinics. I mean, some of my patients have to travel for almost 2 days to get to my clinic. So, and that's very problematic when you have to, for example, diagnose a patient who have problems with its device. But we try to solve this with new innovations, such as, for example, the Neurosphere that is coming to Sweden. We are very happy about that. We actually primarily work with pain clinics. The pain clinics, they actually make the diagnosis, and they also patients physiotherapy, psychological therapies, and medical management. And if the patient have a neuropathic pain syndrome, then they send a referral to one of these neuromodulation centers for the neuromodulation therapy. And we have tried also to open up new referral pathways by getting out the news about neuromodulation to the surgical specialties like the spine surgeons, the hand surgeons, the orthopedic surgeons directly, so that they are aware of this option and that they can influence the pain clinics to send the referral to us much earlier. So we are actually working a lot with new referral pathways here in Sweden. And I mean, this is an indication that is growing. We are operating more and more patients, and we are actually trying to start a nationwide registry for neuromodulation in order to see and be able to follow up our patients and see the results on the nation basis. Thank you.
Well, Pedram, I wish we could see you. Certainly, it was good to see you recently in France, but certainly, I think your experience is great. You mentioned the referrals from the pain centers. And you're in the Nordic countries. Is implantation done mainly by neurosurgeons or mainly by interventionalist, anesthesia-based folks or physiatry-based folks?
Mainly, actually, neurosurgeons and anesthesiologists, and often the pain clinics don't do the implantations. Actually, they find the patients, and then they send the patients to a center who do the implantation. So we are actually, our center is actually not involved in other pain therapies beside neuromodulation. That can make our clinic to be more focused and more specialized on only this aspect of the treatment. But we have still very close collaboration with the pain clinics. We meet several times each month and talk about the patients. And I mean, we phone each other several times a day, discuss different patients and so on. So it's still a very close collaboration, but it's 2 different clinics.
Pedram, I was really impressed by your talk when I saw you at the INS as well, and the work that you're doing in Sweden. Very quick question. How do you, I know that you have patients coming 150 miles or more from different parts of Sweden to your clinic. How do you overcome these issues, and how do you follow up all this patient referral in terms of maintenance of the therapy and other things like that?
Yes, it was a big problem from to start with, but we have developed these digital tools in order to be able to follow up our patients with digital questionnaires that is gathered. The data is gathered digitally and analyzed, and we have also in the system different kind of alerts. So if a patient is not using her system, or if the patient is not doing very well, then we get the alert for that patient so that we can contact that patient. The big problem have, however, been that if we detect that one of the patient is not doing that well and want to meet that patient, then the patient have to travel like for a day or two to our clinic to just have a checkup so that we can see if the system is working or if we have an electrode dislocation or what. And then the patient have to go back home, and again, after a few weeks, come back for an intervention if it's a revision that's needed. So that have been one big issue, and I think that you have to think outside the box with the problems, with the kind of problems that we have in Sweden. And I think that you have to implement new tools in order to be able to help the patients in best way. And the new tech solutions that are coming are really, really nice. And I think that we can increase the quality of the service that we provide for our patients.
Thank you, Pedro. Thank you.
Good job.
So, good job.
Thank you.
So we're gonna move to the next panel. Daoud, yours.
Yes.
Yours.
We'll have our next panelists come onto the screen if they could. We're going to talk about, again, staying on the topic of neuromodulation for chronic pain. Previous slide, gals. SCS, we're going to talk about new and emerging therapies. You know, obviously, internationally, a lot has been happening with spinal cord stimulation and advancing and improving the therapy. So we're going to have our experts from around the globe kind of give us their impressions on things that are exciting, what things have been going on. I'm going to start with Dr. Vallejo. Dr. Vallejo, you've spent, you know, the greater part of more than a decade developing a new and novel therapy for patients with chronic pain using spinal cord stimulation. Can you, obviously trying to tell you to summarize everything you've done in a few minutes is very difficult, but can you share with our international community kind of what you've been working with and what we've kind of launched across the United States with some of the new therapies that you've helped develop?
Thank you, Daoud. So first of all, just let me reemphasize that our lab has been working for the last 2 decades, and we are trying to understand the mechanism of action. You may feel, well, what is the relevance of that? And I think that the relevance is because if we can better understand what is going on when the neural tissues, not the neurons alone, but the neural tissues are exposed to electrical fields, we can formulate different hypotheses and work with them to provide therapies for our patients. And I think that it is relevant because we as physicians, that's what we do. We prescribe therapies to our patients. We are not really into the business of generating new technologies. Technologies have been extremely valuable for us over the last 15 years or so. I have seen how we first had rechargeable systems and they became so popular. Then we got MRI compatible systems. We have systems that can provide some feedback in terms of objective data for patients' activity. And recently, over the last 8 or 10 years, there has been a lot of emphasis in have some type of closed loop system that provide us with the ability to modulate or titrate the perfect dose for our therapies. So I think as we move forward in this field, and I think differential target multiplex is just an example of what can come out of the use of these basic science concepts in terms of application to humans. But what I see in the future is the ability to combine these therapies, this better understanding that goes beyond just the neurons, and combine those with these novel technologies. And I'm very excited about what is going on, but I want to also refer to Yogi Berra, this baseball philosopher, which one time he said, it is difficult to make predictions, especially about the future. So in terms of the title of this presentation, I think it's very difficult to know what is going to happen, but I see a bright future. I want also to end up with one last thought that I think is very valuable. We are observing more changes at the molecular level, whether it's genes or protein expression, than those caused by just the injury itself, which means that the application of electrical signals to neural tissues or any other tissues in the body has a tremendous potential to be an alternative for our patients beyond the traditional medication or other types of therapies that for the last 50 or so years.
Ricardo, that was great thoughts. I think work so far has been pretty impressive. Hopefully you're not done yet. Hopefully another couple of decades. I want to stay in the region of the world, Spain. Dr. Abijan, what is exciting to you? What have you been doing recently that really excites you?
Good afternoon, everyone. First of all, I want to thank the invitation to join all of you. For me, it's a pleasure. In my point, I think what we need to look for is what are we doing. I mean, the most important thing is to know if we can to send something. In order, it's like the closed loop, like Ricardo told before, that we can have any cap in order to know what is the best amplitude the patient need. But what I am looking for is to know what is the sign we need in order to get the good outcome for the patient. I think we don't know when the patient say if they decrease on pain 2 points or something like this. That is the few value for me. We need to have some record, like in the cardiac device, in which you have the signal that we need to have. And I think in the future we will need to send something, some sign or something in which we can have an idea when you are going to have a good outcome or not. But with the rest, I think now the one of the best system is DTM from Ricardo, because we are trying to stim not just the neuron, but also the glia cellular or something like this, something new. And on the other hand, I think we need to know if we are doing the correct thing or not. This is my point, or what I would like to looking for in the future.
Love sensing and reaction is a great advance. I know you've been doing that in Spain, and I certainly can't wait to see the real world outcomes there. So thank you for that. Rita, you're muted, bud. We had to have at least one of those.
Yeah. Sorry, guys. So thank you, David. And I would like to ask Leo, my good friend and mentor. You've been working in tons of studies and for decades. And I'd like to ask you what's new in the field of neuromodulation that you're working on that you can tell the international audience here.
Oh, thank you for having me. This is such a nice panel. Thank you, Rita. Thank you, Tim and Dawood. And I so enjoy joining David and Jan. This is a super panel. So yeah, there's several therapies. I mean, my involvement with 10 kilohertz and with Ricardo and his DTM and closed loop stimulation, all of three showed the great outcomes in a prospective randomized study in level 1 evidence. Now going forward, there are several therapies in spinal cord stimulation that I'm currently working on, and two of them are really interesting. One relates to new approach on spinal cord stimulation, and it's featured by a large German company, Biotronic. We finished temporary trial, which really showed benefit, great benefit of this new approach compared to all of the other players in the field. And we presented that abstract on 140 something patients a little while ago. That now goes into the larger implant study, and hopefully we'll see those data very soon. The other one that I'm really looking forward to, we're going to initiate a first implant now, and literally in a month or two, is the ultra high pulse radio frequency of dorsal column with with small company Jimmer from Taiwan. It's an interesting approach. Stimulation goes on for about 5 minutes, and pain relief goes for about 4 to 5 days. Obviously we are stimulating at rates of 500,000 hertz with very small amplitude toward the dorsal column. The safety studies in animals were perfect. The initial data in humans looking really good. There are about 20 patients now implanted with the device, and so we are looking forward to see how this will develop long term. And from the standpoint of peripheral stimulation, we just finished enrollment in beautiful study with neuros. This is 10,000 hertz cuff lead peripheral stimulation for control of the phantom pain, and then we're going to be very soon presenting those data. I was fortunate to be a PI on that study as well. It took us a long time ago. It's a tough patient population, as you know. Those are the patients who may have social issues, and really, but it's really great feeling to help those folks get off the opiates and control their phantom and stump pain. It was a very large study, over 160 patients. And the nice thing about design, it's a sham study. So we are looking forward to more sham studies in the field. And again, we are now collecting 3, 6, and 12 months data.
That's great.
Amazing,
Lee,
Leo.
you've done such a fantastic job with developing the literature and data for all these new and emerging therapies. I always ask you kind of what's coming next, and because you've already kind of working in the preclinical models and some of the pre-FDA models and those types of things. So I have a question for Dr. Kalaward. You know, you recently published with your colleagues a really nice real-world outcomes on combination therapy for spinal cord stimulation in Europe. Can you share some of the highlights from that study? Because I really thought it was outstanding work.
Thanks a lot, and to begin with, let me thank you guys for organizing this and building such a great community. What Tim said in the beginning, which should be really international and should be basic for us, for all countries to work together on all field of pain management. And thanks for the other speakers here before me, because let me before I ask your question, before I answer your question, is what is so important for me is that 2 years ago we almost lost neuromodulation in the Netherlands because we had issues with our health insurance companies and the government above that, and because of the studies that were done, happily we could keep 80% of the indications, but also we've lost some of them. And like Leo said in his last few words, is that happily CMN studies are done at the moment, like for Virgin Back 3 studies in worldwide. I've discussed it with Tim in Paris for DRG, is that we need a lot of better studies for specific indications to really get all these indications insured for the future in the world with all new therapies that we have. And then if we come back to the combination therapy, I think the best thing, the best result of this study was it's just real world data. And what do we need is real world data. We need thousands of patients put in registries to get those data out. And this happened in this study, but probably what we should do is, like I heard, there's a registry in Sweden, there's a different registry in Germany. We've built a registry. That's one of the advantages of the discussion we had with our healthcare institute. We have a mandatory registry in the Netherlands now, and everyone has to put all their patients in there. But it's not only indication, it's also what kind of leads do you use, what kind of frequencies, how many times do the patients visit the clinics, what are the outcomes, and using that maybe with thousands and thousands and thousands of people, we are better able to select our patients, because I think selection is everything. With selection and prediction, we can also better predict what will be the best therapy for this individual patient, and hopefully, for example, with this community, and I'm happy to show you those Dutch results in the next meeting, and maybe we should set up a meeting. What are different registries in the different countries? Because that's the way we can come out with it. And we did that in a small session with with the study, with the real world outcomes that we've published in the Western of Europe, but that's just the beginning of what we should do.
Well, great thoughts. I think everything you said, I totally agree with. And I do love the thoughts on long-term registries and outcomes and real world data, because all the things that was discussed earlier, if we can't produce that in the real world, it won't matter. I want to finish this panel with a question for all of you, and I'll go in the same order we went with before. So Ricardo, you're going to be up first, and Jan will have the hardest job being last. But just a really quick answer, and that is, you know, I'm a forward thinker. We have, I think, of our 4,000 members, over half of them are under the age of 45. So we have a lot of young people. And the question is, 5 years from now, what is it that's going to be out there in 5 years, in your opinion, in this area of science and treatment? We don't currently do at the moment, but that's in investigational modes, you know, just now beginning. What in 4 or 5 years is going to make a major difference for our patients? Ricardo, you get to go first with that. We'll have everybody give one. You only name one thing, because we don't want to take too many things along the way. So one thing yourself, then David, then Leo, then Jan.
I think it will be a combination or blending of technology, and I mentioned specifically ECAP with other types of therapies, whether they are supra or most likely with the use of subthreshold stimulation. I think this blending will bring, for the next 4 or 5 years, a lot of new evidence in the field, and I'm very excited about this work.
Great answer.
In my point, I think the use of ECAP with another system we have, with a combination like Jan told before, with something like the stimulation with DTM or high frequency or something like this, with closed loop, is my thought.
So it sounds like you both are thinking the sensing and responding will become important. You know, there's going to be measurement, which will be important, but then the response of real world response of the cord to the device, vice versa. I love that. Leo?
Well, I mean, we didn't have, we came back to the normal state now, because for 30 years, we really didn't have level 1 evidence. There were 3 companies that had main business in cardiac pacing and other spine therapies, and that was what was bringing the money. This was their side business, and really didn't come to that point where we would get number of the studies. This is now going to crystallize what we're going to use in the future. I think we need much more. This is very interesting area, but it's really difficult to make assessment. It's a chronic pain, patient subjective responses, functional capacity assessment that all complicates this whole issue of how do we measure very proper outcomes. So I'm looking forward to see, and thanks to ASPN, we also added some more of the encouragement, especially to the young folks, to conduct independent studies, to see more in the future that will enhance this therapy, and whether that will be high or low frequency or closed loop, or you name it. The main thing is to be able to compare and see what we're going to be able to use in the future.
And I think what you said ties in really beautifully with what everyone else said, in that, you know, if we can find outcomes that are unique to an individual, we may be able to then to pick which of those blended therapies are the best for that individual, and individualized therapy. And if we can do that, that would be amazing. Jan, your thoughts?
Yeah, thanks for being the last, and everything is said. So I thought I just give an absolutely different answer, because I think what Ricardo, David, and Leonardo said, that's true. That's what we have to do. With doing that, hopefully in 5 years, we'll have 2 big indications as official indications indicated in our field, and I'm talking about a real big group. Leo, your interest, abdominal visceral pain, and especially what we're working now is that the non-operated low back pain is becoming our primary kind of interest. And with doing that, I'm hoping that in the algorithm we are really before opioids and before surgery. If we can do that, then we are all happy, guys and girls.
That's wise words from the wise people. I do think that we're going to actually merge everything. It used to be injections or neuromodulation. I think we're going to merge everything else. So it's a big continuum, and I think that'll be a great thing. Rita and Dawood, any final thoughts on this panel before we go to our last panel?
No, I mean, I think it's, very telling, to see what the leaders internationally, are excited about. That's kind of how I learned, what's really going to be up and coming, and all the work that, all of these gentlemen have done has just led us to where we are right now. And I think we're on the precipice of, an explosion in this field. I think we're really just kind of beginning. I think the next 10 to 20 years is really the golden age of neuromodulation. Thanks to all of you. So thank you so much.
Amazing talk. And one thing I would like to mention is how can the leaders in the field work with the companies to push those newer therapies to the areas that are underserved and to other countries so they can adopt this early on. Because what I noticed sometimes there is a lag. So things that have been available 7 or 8 years ago start to appear in those areas of the world. So we can all get together and try to push those therapies and try to push it to the areas that are lacking in neuromodulation. It would be a great thing. So thank you, everyone.
Thank you.
So we're going to move
Thank
to
you
the
so
next,
much.
our next panel here. And our next panel will talk about intrathecal drug delivery. And we have two of the world experts in the field of intrathecal drug delivery. We have Dr. Eric Buchner and Dr. Christophe Perichou. And first, Dr. Buchner, we're gonna start with drugs and combinations, and then the podium will go after that to Dr. Perichou. The podium is yours, Dr. Buchner.
Yes, hello. And thanks very much for the invitation to this very exciting meeting. Well, in short, the problem with the drug mixture is that from an early study that was done by Sam Hassenbusch, I don't think that has been replicated since, but it shows that about 2/3 of patients do actually change from morphine to something else. And the reason they switch to other drugs is essentially the lack of efficacy. About 20% of those patients do switch because they do have side effects. Now, as you all know, the only drugs that are recognized and admitted for intrathecal pumps are morphine, clonidine, morphine, baclofen, and ziconotide. Now, it turns out that if you look at what people do, they mix up to 15 different drugs, sometimes 4 or 5 different drugs together in the pump. Now that has allowed allegedly some good results in cancer patients. There are reports from France where a group has used combination in high concentration for quite a number of years and reported good to excellent results. Now, there are a few problems with the mixer, the drug mixture. The first is that there is an interaction between drugs. But for instance, there is an oxidation phenomenon that goes on, and if you use drugs like ziconotide, there is virtually no drugs you can use. You can mix it with because it gets degraded pretty rapidly. And the other thing is that you may have problem with drug concentration. The drug concentration, the true concentration in the mixture is something that's important. When you start mixing drugs, some are because you need small volumes. You need to increase the concentration, and therefore you may increase the risk of all sorts of side effects, including lesions of the spinal cord itself, because if you have that, you do have a neurotoxicity, and
So Eric just froze. Eric, I think you're frozen at the moment. So I think Rita, if you want to join me again, we'll move forward here. We have a policy. It's like if you drop a flag, keep rolling. Maybe back to freezing of your system for a moment.
Can you hear me?
Yeah.
I can hear you now.
Yeah.
All right, something's happened. I don't know. Still there?
Yeah, you're good now, Dr. Busher.
You're good, yeah.
Okay, thanks. I don't know where I lost you, but I was just getting on the potential toxicity, particularly with the high concentration of local anesthetics that do produce neural damage that may be irreversible. So the last problem is what the mixture are susceptible to do to the pump, and well, the manufacturer claimed that most of the rotor oxidation corrosion they have was due to the use of drugs at high concentration that are not recognized for intrathecal use. Now, this is a problem that used to be with the earlier versions of the pump, particularly the Medtronic pump, which apparently is now solved because they changed the internal tubing. But nevertheless, the problem remains that you do have potential complication when you start using different combination of drugs, which are to some extent not necessarily predictable. As a last remark, I think that we should, as a rule, remember that the daily dose generally accounts for most of the side effects, whether the concentration in the CSF accounts for the neural toxicity. So there are recommendations that have been published by in the different consensus that have come up, would suggest the maximum concentration of the most used drugs, and that includes particularly morphine, hydromorphine, bupivacaine. And I think I will end here.
Well, great comments, Eric. I think you've been a great leader in safety overall. We're going to go to Christophe in a moment for some comments, but what's your big, if you had to give one pearl that to lower the risk of intrathecal drug delivery, what would that one pearl be to younger viewers?
Well, I think that if you have to use combination, which you obviously have to do in a significant number of patients, I think that the follow-up of those patients and to get them in and follow them neurologically, and if needed with MRI, since all those devices are now compatible with the MRI, I think that is something that should be put forward first, because otherwise there's not much you can do. And the thing is, when those changes or when the toxicity are picked up earlier, that includes the toxicity from local anesthetics. When they picked up early, they're mostly reversible. It's a problem when you let them go. Then this is when the problem comes.
No, I agree. I think the two things you said that really resonate with me was, the concentration recommendation we've made together, and you were part of that with me and other folks. Really, I think it's safe. There's a lot less granuloma now. So I think that's been a major impact on safety. And then the other thing you said that I think is really important is MRI. In 2003, I did a study. I MRI'd a bunch of people in a row, I think 200 patients in a row, found 3% had we didn't know about, right? Which was kind of shocking. So thank you for that. Rita, you want to kick off Dr. Perishild's comments?
Yes, so Christophe, we're happy to have you here, and we want to actually share your thoughts on, if you talk about adverse events and the management. I know you have some slide presentations to share with us, and a lot of young folks here that would like to hear about, managing the pumps, because a lot of people or a lot of physicians, they are comfortable putting the pump in, but sometimes managing how you overcome and not to be scared and how to properly manage the pump and the adverse events that could happen. So the podium is yours.
Thank you very much, Reda. Thank you, team. Thank you for the invitation. I don't know if you have my slide or if I can just talk like this, but basically, oh yes, here they are. So basically, as you know, the complication or adverse events linked with intrathecal therapy can be divided in three categories. It can be linked directly to the infused drug. It can be linked to the procedure itself, or it can be related to the implanted system, the pump, the catheter, and all the connection. And in this study published 20 years ago by Cameron, you can see that the top three complications are first ranked the drug adverse event, followed by the catheter problem. It can be kinking, it can be occlusion, it can be breakage, it can be migration. And in the third position in this top three of the complication, you can find the infection, either superficial or deep infection. And next slide. You can see that also, yes, please, next. And in this more recent publication published last year in collaboration with Lisa Stern, you can see that things didn't change a lot. And the most frequent occurring adverse event is still the adverse drug reaction, 1/4 of the complication, and also the medical device side pain. Catheter is still a problem, despite the progress that is done with the new design of the catheter, with the new catheter. But you can see that the dislodgement rate, the catheter occlusion rates, kink and breakage are still in the same range than previously. And it's also important to note that in this study, in the cancer pain population, that the infection rate is not very different from the non-cancer patient. It's about 3% of the implantation. Next. The other complication related to the procedure can be hematoma, CSF leakage, seroma, or neural injury. And one also important complication and not rare complication is this post-puncture headache occurring in about 20 to 1/3 of the patient. Next slide. And very recently, the team of Denis Dupoiron published a very simple procedure consisting of injecting fibrin glue just before anchoring the catheter. And you can see in in this MRI picture done at day 1 that you have this diffusion in the intrathecal space of the fibrin glue that is completely reabsorbed at D10. And this simple procedure allow the drop of the complication of this post-dural puncture headache from 32.7% to about 11% after this injection of the glue done recently by the team. Next. It's also important to remind that the problem not only occurring at the implantation time, but it's also linked to every manipulation of the pump. It can 1/3 of the deaths occur 3 days after the pump refill, change of drug dose or concentration or reprogrammation, but also some problem and many complications also happen after pump or catheter revision. So it's not only the pump implantation that can be tricky for this increased mortality risk, but also every manipulation on the pump. Next. Next. So you can have some picture here of illustration of the complication related to the device. The more frequent are this migration due to the rupture of the suture of the anchoring. You can have this flipping of the pump that is now clearly and easily identified with the ultrasound. You can have this kinking. You can have the leakage of the connection site of the pump. And next. And we also identify a quite rare complication, this backflow from the silicone septum, resulting in a pocket fill and the overdose in some patients due to the loss of patency of the silicone septum. Next. And as I said before, the most frequent complications are related to the medication, especially opioid. You can have this dependence, tolerance problem, constipation, nausea, urinary retention. But it's also important to remind that these hormonal trouble are very frequent, like the hypogonadism that occur in about 60 to 100% of all the patients. So you can have to be aware of that if you have patient complaining with fatigue or a sexual disturbance or breast discomfort. It's worth to dose this hormone in those patients. You can have metabolic trouble with hyperlipidemia and obesity, which is not rare, 1/3 of the patient, peripheral edema, and also granuloma formation related to opioid. Next. And this granuloma formation occur with all opioids except fentanyl. It's often present with a loss of therapy efficacy or neurological deficits. And the worst scenario is this high concentration and low flow rate. You can manage this conservatively in many cases. If possible, it's the way to go. And it's also seems to decrease with the bolus administration. You have less exposure at the dura with high concentration morphine. Next. Adverse event linked to ziconotide. It's mainly neurological complication with dizziness, nystagmus, confusion, memory impairment, but also some severe psychiatric trouble, especially in patients with a history of psychosis, and you can have also an increased risk of suicide. Next. Adverse events related to bupivacaine or local anesthetic is mainly a neurotoxicity, especially with high concentrated solution, extremities weakness, paresthesia, hypotension, or urinary retention are also a frequent adverse event with local anesthetic. Next. And with clonidine, the main adverse event are sedation or hemodynamic complication like hypotension. Next. And I can strongly recommend you to refer to this PAC and PAC paper published a few years ago. The new version should come in the very next future, hopefully beginning of next year. And in this polyanalytic consensus conference, you have one of the 3 papers dedicated for improving safety and mitigating risk. Thank you very much for your attention.
So Christophe and Eric, that was phenomenal for both of you. So I have one quick question for, I don't know, I think Eric's still with us, hopefully, for both of you, but I'll start with you, Christophe. And that is, therapy is an important part of treatment for cancer and non-cancer. So Denise, Perion's paper from France and Lisa Stearns, who we all miss. Is pumps going to grow in the future, or are pumps going to go away in the future? What's going to happen with intrathecal drug delivery in the future, in your opinion? And I'll start with you, Eric.
I didn't get the beginning of the question because it was some loss of connection, but the end of the question is if there's any future for intrathecal pump. And I think, of course, obviously, the answer is yes. And we had recently this very nice debate, and you were on stage, Tim, to see if we have to limit or to restrict intrathecal drug delivery for cancer pain, and the answer was clearly not. Of course, it has to be, we still need some more evidence for non-cancer pain, but I think for cancer pain, we have very clear and robust data to support this therapy for refractory cancer pain.
Great thoughts. Eric, your thoughts on that question?
Yeah, well, I think one of the main problems with intrathecal drug delivery is that it is very work intensive. And this is maybe something that is going to be a problem in the future. Now, regarding the evidence, if you look at NICE, for instance, they have stopped, in Britain, they have stopped reimbursing intrathecal pump, at least for non-cancer pain. Now, I know that they are challenging the reimbursement for even for cancer pain. So, you know, I think it is that there are undoubtedly there are patients who you cannot treat without. Now that is still doesn't mean that the therapy is going to grow because of the work intensiveness, because you know you need dedicated center. As soon as the patient is living a bit too far from your center, it's a big problem in terms of when there is something that's happening in terms of either over or underdosing or whatever. So I think it needs a few adjustments until we can get there.
No, I agree with both of you. I think it'll persist, but I've always said we need a new drug. We need a new non-opioid drug, and we just don't have it yet. And so, Rita Dawood, your thoughts?
Yeah, you know,
Yeah.
go ahead, Rita.
Yeah, I think the future is there, but I think, like Tim said and Eric as well said, that we need to develop a new drug, and also we need to work on reimbursement and work with the societies to improve that. But my question is because that was debated, and we have the similar issues in the US as well. Do you guys trial all the patients or not? And in terms of trialing, there's been a debate whether we should or should not. And I know this is a whole different discussion that needs time, but what's your very quick thought on that?
Well, for cancer pain, we usually not trial them except if it doesn't delay or postpone the procedure. And for non-cancer pain, we always trial them with single shot bolus, not with external catheter.
What Dr. Bushner thinks about that?
Right. Well, we do the same thing because we come from basically the same center. So yes, single shots for non-cancer pain. Now I still use single shot in cancer pain when there is a risk of urinary retention, because I want to test whether the patient is going to have this kind of problem. And if so, you know, people have to know.
Thank you. Dawood.
Yeah, well, thank you so much, gentlemen. This was really enlightening. I think therapy has, you know, been a mainstay of pain management, and hopefully it continues with all the great work you guys are doing internationally. So thank you so much.
Thanks, gentlemen. Hopefully.
Bye-bye.
Dawood, what do you think?
Well, thanks. You know, I think, you know, just some closing thoughts on, you know, this program. I think, you know, there's so much that, you know, we can learn from each other. I think, you know, when, you know, Rita came to you and I about this concept of ASPN, this is really what it was all about. You know, I think that we know that we recognize that the field of, you know, pain and neuroscience is advancing so quickly, but there's also such a big desire for more awareness of these therapies. And with Dr. Doshi's talk, that awareness of these therapies was a big, you know, limitation. So I think one thing that, you know, we may not be able to solve all the problems of access, but I think we definitely can help with awareness and education. So I think this is kind of the first step. Rita, tremendous job with this, and look forward to kind of continuing this great work and culminating with our first annual meeting sometime soon in Dubai. So I think it's going to be really exciting. I think a lot of people are very excited about having the big international in-person meetings. So Rita?
Thanks, Dawood. Again, I would like to thank all the panelists for this nice brainstorming, and I'm looking forward to our meeting in Dubai. Again, our mission is to get all the brightest minds all over the world, and we have a very successful society introducing new therapies, raising awareness, and improving also the accessibility to those therapies in the future. And there's also Dr. Sam Eldaba, who couldn't be here, but he has a nice slide presentation that we'd like to display at the end of the sessions here. So whoever wants to stay here and watch the slides, it's available. And also the session will be recorded and will be available on the website as well. So we're looking forward. Again, I'd like to thank everyone who attended today. I'd like to thank Tim and Dawood, who worked tirelessly with me to make this a success. And we're looking forward for all the participation in our next webinar that will happen in December on radiofrequency ablation. We'd like to thank our sponsors as well today, Medtronic and Abbott. And we're looking forward to see you soon in December. And also we're looking forward to work with everyone to join our future meeting in Dubai. Thank you, everyone.
Thank you.
Hello and good morning. My name is Samuel Darby. I'm a consultant anaesthetist practicing pain medicine at the James Cook University Hospital in Middlesbrough, UK. And I am going to talk to you about the process of patient selection and trialing for intrathecal drug delivery, particularly with reference to chronic non-malignant pain. The patient selection process begins with a usual medical evaluation consisting of history, examination, and appropriate investigations, particularly in cases of back pain. MRIs and EMGs may be helpful. We then conduct a psychological evaluation. The psychological evaluation aims not to identify suitable subjects, but to exclude unsuitable subjects, such as people with substance abuse, those who have significant psychopathology, issues of unresolved secondary gain, and people who have no social support to allow them to attend the hospital for frequent refills. We also conduct a physiotherapy evaluation looking at function and its relationship with disability. This is followed by a team discussion, and if the team discussion identified the person as a potentially viable candidate for intrathecal drug delivery, a trial is then taken forward. So before we go to talk about trial therapy, there are quite a few questions about trials. First of all, are they necessary? And if we do them, do we do boluses or infusions? Do we do placebo trials? If we do boluses, do we do multiple or single bolus? Do we aim for 50% pain reduction? And well, how long for? And is a home versus a hospital trial, does they produce different stories? So basically, what we are trying to do with the trial is very much like an engagement before a marriage. And from this invitation, you'll see that possibly not all engagement produce a good marriage. So a trial is a period of engagement to attempt to identify those who would benefit most from intrathecal drug delivery in the long term. In order for us to look at the predictive value of intrathecal trials, I would like to invite you to review with me this paper by Dominguez et al. Although it isn't a brilliant methodology, it does contain enough patients and enough information to be extremely helpful for people who are contemplating a trial. So the authors reviewed 134 patients from 157 patients trialed. This is a success rate of 85%. They had complete medical records of 64%. The rest were either lost to follow-up or explanted. What did they collect? They collect data on age, gender, diagnosis. They also collected the drug and dose used at trial, and then the same drugs and doses used at the initiation of therapy and every 6 months afterwards for 54 months. So basically, they are trying to relate the dose of the drug at trial to the dose of the drug at long-term therapy. So the trials were done by sequential lumbar punctures with 1 or 2 blinded placebo injections. They identified 3 dose ranges of trial: the low, the standard, and the high dose ranges. And you can see the doses for low, standard, and high doses. Here are the patient demographics. You can see the majority are female, aging late 50s, average follow-up 18 months. The majority suffer with low back pain with some visceral and peripheral neuropathy, stroke, CRPS. This slide is quite an interesting slide because it shows you the dose escalation in intrathecal opioids over time, over the first 24 months. And you can see a very clear difference between the group that had a high dose trial with a dose escalation to about 35 milligrams and the groups that had a medium or low dose trial. And you can see that both of these groups at 24 months are still under 10 milligrams per day of morphine. You have to remember that the dose escalation is physician dependent and rather dependent on practice, but it also can be taken as a surrogate indicator to whether the patient continues to complain of pain. Another surrogate indicator whether the patient continues to complain of pain is whether the opioid is substituted. And we can see here that the low dose trial opioid substitution is very low. The use of adjuvants such as clonidine and bupivacaine amounts to about 10% in the low dose, 20% in the standard dose, but 40% in the high dose. Opioid substitution jumps from almost nothing to 15 and then 25%. Let's park the indications for now and look at the age and gender impact. The age impact, it's very clear that patients over 65, which are the solid lines here, are basically using much less in the way of opioids than patients under 65 who are using a much higher escalating dose. The same is true for females versus males, where females are using much less over the first 24 months than males. So the authors conclude, perhaps not unreasonably, that the degree of response to intrathecal narcotic trial period taken together with the age, the gender, and perhaps the indication have a predictive value on long-term utilization of intrathecal analgesics. So let's now address some of the questions that we asked earlier on. In order to answer these questions, which are many, we are going to be looking at what is the evidence available. When we compare bolus to infusion, it is very clear that the most important difference is the expense. Infusions are expensive because they have to be carried out in hospital, the majority of, whereas boluses are cheap as they can be done in outpatients. They have a lower risk of dural puncture headache, but as opposed to infusion, which may in occasion carry a higher risk of infusion headache because of the need to insert a catheter. However, the two produce a very different profile of response in patients, and here we can see from the work of Chris Bernards and his colleagues the difference in the drug spread around the tip of the catheter, which is the central point of the graph, in time, and you can see that at an infusion of 20 microliters an hour, which is very similar to what a synchromed pump or programmable pump would be infusing, you can see there's very, very little spread around the tip of the catheter. However, when you change the profile to a bolus of 1 ml over 5 minutes, you'll find that the spread is going further to up to 7 centimeters from the tip of the catheter. It also spreads anteriorly and posteriorly to the spinal cord. So that means that the infusion and bolus trials produce different responses due to different patterns of spread of the drug around the tip of the catheter. Looking at the methods of administration, let's examine what can be used. So port systems allow a longer trial period. They have a lower rate of infection. You can use infusion and boluses, or you can do them in hospital or at home, and conversion from a port to intrathecal pump is very easy to do. Next slide is showing Where do you insert your catheter? Inserting your catheter, according to the national US survey that we mentioned, most people insert the catheter position according to pain. So in failed back surgery, the catheter is inserted at L1, and sometimes between T10 and T12. In multifocal pain, it goes higher, etc., etc. The dural puncture headache estimates are 0 to 60% during trials, and this is difficult in assessment of pain. Here you will see that this catheter is in a dorsal position, i.e. behind the spinal cord, and this is an ideal position for a catheter. Therefore, one should always ensure that the catheter ends in a dorsal position. These are a number of pumps that I've showed you that we can use during the trial. There is a fundamental difference between them, and that is the infusion rate and how much they're able to mimic the action of an intrathecal pump, a long-term implant, a programmable device. So the two on the left, the CAD Micro and the CAD MS3, are quite easily mimicable because they can produce infusion rates as low as 48 microliters a day, which is exactly the lowest infusion rate of a Synchromed pump. Whereas you can see for the two pumps on the right-hand side, the Abbott provider of the CAD Legacy, the lowest infusion rates are 2.4 mils and 1 mil respectively, which is quite a different situation. Looking at the bolus trial techniques, bolus trials, you can see that from the US National Survey, the needle sizes range from 18 gauge to 27 gauge. I wonder who uses an 18 gauge for an intrathecal injection. The 25 gauge, unfortunately, is the most popular. When we look at the size of the bolus injected, you'll find a 100-fold variation between practitioners, between 0.03 milligrams to 3 milligrams of morphine. How the people arrive at the size of the dose injected, some divide by 100, some divide by 600, however, the majority divide by 300. 73% use a repeat bolus, and most report a low incidence of dural puncture headache. Now here we're asking the question, if you wanted to conduct a trial that very much mimics what you have done or what you are going to do when you implant a pump, this may be the way to do it, is to implant a port system, connect it to a definitive catheter, which is the Endura catheter that you are going to utilize long term, attach it to a pump that produces an infusion rate similar to a Synchromed pump, and you have a system that is very similar to the long-term infusion rate. The advantages are the system is adjustable in duration, so you can do a trial for weeks or months. The trial can be conducted at home. The infection rate is low. You can use it for ziconotide, and the catheter tip is at the position you're going to use it for, and the flow rates are comparable. However, having said that, there are disadvantages. The system is, once you've implanted this, you're 3/4 of the way towards a full intrathecal implant, and that means that producing a negative trial means that you have to have a major or a more major operation in order to remove this contraption. How do we assess the trial duration? So let's look at what the US National Survey said. The mean trial duration was 4.7 days. The assessment was pain every 6 hours, whether it is the same as we do at James Cook. As you can see, we conduct a 4 times a day VAS plus a global assessment of the effect of treatment daily. Some conduct this on activity, some obtain written logs, and some ask for side effects, others do not. To affect the assessment of trial efficacy, most look for pain relief at rest, some pain relief on activity, and some for minimization of side effects. And successful trials are followed by an implant in the US in about a month time. In 45% of the cases, the rest are due to patient refusal, insurance refusal, etc. Now we'll tackle finally the difficult issue of do we or do we not conduct placebo-controlled trial. Patients should be informed if we are going to conduct a placebo-controlled trial. The question is, are they applicable more to infusion or to boluses? Generally speaking, it is easiest if the placebo is administered upfront, because if you administer a placebo at the first 2 days, then after that, administration of the active drug is unimpeded and you cannot confuse the effects of the two. Also, the administration of a subanalgesic dose of morphine may be confused with a placebo. Therefore, it is difficult with boluses to control with placebo more than infusions. So, in conclusion, trials of intrathecal therapy are generally recommended. They can be carried out using single or multiple drugs or single or multiple boluses, can be used using bolus or infusion. The effective trial dose can predict future responses. Bolus trials predict a response to the drug, whereas infusion trial predict a response to the drug at a given administration rate. Thank you, and any questions, please write to me at sldarby@mac.com.